Welcome, everyone. My name's Jill Christians, and I'm a member of the class of 1994 Reunion Committee, and I'm very pleased to welcome you here and to introduce our panel moderator, Professor Joe Doyle. Professor Doyle holds 3 titles at MIT. He is the Irwin Shell Professor of Management and Applied Economics. He is also faculty director of the MIT Sloan Initiative for Health Systems Innovation, or HSI. And he is also co-chair of the health sector of the Jameel Poverty Action Lab at MIT. He studies public economics in the areas of healthcare and child welfare. His healthcare research investigates sources of value and waste to inform policies aimed at improving the quality and cost effectiveness of the US healthcare system. This includes partnering with large healthcare providers and payers to conduct randomized controlled trials of changes in the way healthcare is delivered with an emphasis on addressing social determinants of health. He conducts similar investigations into foster care and juvenile justice programs. Today, he will moderate a panel with a group of MIT Sloan alums at the forefront of 3 very different approaches to solving some of society's greatest health challenges. Please join me in welcoming Professor Joe Doyle. Are you all mic'd?
I'm all mic'd up. Thank you very much. Thank you all for coming. This is one of our favorite things about MIT is the community, not only the current students, but alumni, and it's always fun on graduation day when there are smiles everywhere. This is like the happiest day on earth. It's a small world after all. I don't know, we're not going to sing for you, but I think it's a really fun time to be here. Certainly the topic here is important, healthcare. I'm a health economist, and we economists like to put dollar figures on how much people are willing to pay for things. So a recent paper found that for a 1% reduction in cancer mortality, the US consumers would be willing to pay about $500 billion for a 1% reduction in cancer mortality. We just value healthcare so much. That's why we're here. We really care about each other. We care about making the world a better place. You often hear as a cliche, but in healthcare you really see how you can improve people's lives with the latest technologies, also thinking about the cost side. And we're going to get into all these topics today with a discussion, as well as open it up for a discussion from you. So we're hoping to keep a good 20 minutes at the end to have a discussion with the whole audience here. I'd like to introduce myself briefly, and then I'll introduce our panelists. And to introduce myself, an easy way to do that would be to describe a recent research project that got launched in April in Pennsylvania, where I've partnered with Geisinger Health. Some of you probably know Geisinger. They're a payer provider. So it's an insurance company that also employs physicians and runs hospitals. So incentive alignment is right there in terms of getting people well to keep costs down. You really see that come to fruition in places like a Kaiser or a Geisinger. And they tend to be really innovative in how they treat patients. So one of their recent projects is called the Fresh Food Pharmacy, where they prescribe healthy food to their food insecure, so patients who have trouble obtaining enough food for themselves, food insecure patients with diabetes. And you might think, well, my doctor tells me to eat healthier too, but the difference here is that the prescriptions get filled each week at a clinic where patients come back and get basically all their groceries for themselves and their families, along with education of how to prepare the foods and how to treat their diabetes. Now, in other contexts, if you ask a food insecure patient, hey, you should really go to the food bank and treat that food insecurity, they don't really want to go. There's a big stigma to going to a food bank. Or if you ask them, hey, you should get this diabetes education, it's really important for you, people don't really want to take the time to do that. But by partnering the food provision in a clinic that's been advised by your doctor to go to, this is the way we're training you to treat your disease. You get really high take-up. People go to get the food, and while they're there, they get the diabetes education. So they're expanding to 2 new cities, and we decided, and they partnered with MIT to randomize who gets to start now and who has to wait, because they can't treat everyone on day 1 when they open the doors, because the dietitians have to give them advice, they have to onboard people. And this gives us an opportunity to run a clinical trial for food instead of drugs, for a targeted population where we think it might have a big impact. This food as medicine idea has gotten a lot of attention, the Geisinger program, but more generally. And this idea of treating social determinants of health, things that affect your health outside the clinic, is another hot topic. In fact, CMS, the Centers for Medicaid Services, will allow their Medicare Advantage plans to start paying for things like food, housing stability, transportation, and other social determinants interventions next year. So there's just a ton of interest in how, among payers but also providers, about how do we treat the whole patient and not just when a disease strikes up. So I mentioned that example for two reasons. One, it's my most recent project. It just got launched in April. I'm really excited about it. Another one is that Alistair Erskine, who was the Chief Information Officer at Geisinger, was a CIO at Geisinger, and now he's at MGH. And I got put onto this project basically because I talked to him about what's exciting going on at Geisinger, and he got the ball rolling on this whole project. So we really do value our alumni contacts and talking to you about what's happening out there in the real world on the cutting edge of how we're treating patients or changing healthcare. And as a member of HSI, this is our healthcare center here, alumni dollars actually went forward to get the feasibility study done and to actually launch the initial month of the study while we secured funding from the Robert Wood Johnson Foundation, National Institute of Aging, and the Jameel Poverty Action Lab. So we're actually using alumni funds to get projects like this off the ground so we can learn what works and what doesn't at the frontier. So I wanted to thank the alumni for that support as well. But I would love to start the conversation with our panelists, an illustrious panel that we have here. So first I'll introduce each panelist, and then we'll go to each for some opening remarks. But Phyllis Lantos is the former Chief Financial Officer at New York Presbyterian. And she's my go-to person to figure out how do hospitals actually run, how do you make decisions. And she's an expert in the intersection between hospital management and public policy, having to deal with a lot of regulations, whether it's New York State level or at the federal level. Then Chris McLeod will give us an investor perspective. He's a managing partner at Elm Street Ventures, which is a life science venture fund. Has a lot of experience in a number of industries, which I think is great to give different perspectives on how healthcare is and should be proceeding, and especially in biotech, gene sequencing, and the like. We have some fans. That's very good. And then we have Linda Vahdat, who's our clinician expert on the panel. She's the head of hematology and oncology at Memorial Sloan Kettering. And she has obviously a lot of expertise in oncology, both from a clinician perspective as well as a research perspective, having done primary research on drug development in the treatment of breast cancer. So as you can see, we have a number of viewpoints here, and we're going to think about the future of healthcare and how we as a community can help lead to get us to a better place in healthcare. So I'm going to ask you guys each to have some opening remarks, and we decided that it would be fun to think about where have we been in healthcare, where are we going in the next, say, 10, 15 years? Maybe think about where should we be going, but where do you think we'll be heading? So Phyllis, why don't we kick it off with you?
So I'll start with that, but I go back in healthcare a long time now. And Medicare, Medicaid, the different payers have paid differently. I have a financial perspective, really, have paid differently over the years. They used to pay whatever the cost is, then they put caps on, then they said, we'll pay you per case instead of per day, and on and on. And now we talk about even payments per episode, maybe over a 9-month period. Bundles that will pay for the doctors and the physicians and the hospitals together. So a lot of changes over the years. What's clear is we spend more and more of our economy, the GDP, it's close to 18% now is going into healthcare. That's enormous. It's grown. It's larger than any other country. I will say, on the other hand, other countries do spend significantly more on the social service costs of taking care of their population. Hence, when you talk about social determinants of health, we have that embedded actually in our healthcare system. So a very simple example is we find that if you have children that are living in socioeconomically deprived areas, the asthma rates are very high. And then what we started doing is putting air conditioners in those homes as the asthma rates go down. So there's a lot that we can do around food security and also physical security for individuals. If I look to the future, there's just going to be enormous pressure on the finances. We're all, not everybody in this room it looks like is getting that old, but the baby boomers are hitting, and Medicare is increasing 10,000 members per day. So that means we're going to have a lot more people who are older. The use rates for people who are older are maybe 3 times what they are when they're younger. And it's not OB anymore. Now we're dealing with more cancer and heart disease, et cetera. So we have the train running down the track. And then actually the younger part of the population, the obesity has been enormous. And that's the diabetes that's coming down the track. So the question is, how do we convert what we've done into a more efficient and effective methodology? And I think you're going to hear in some of these areas where the effectiveness and actually efficiencies also are the hope for the future and how we disrupt ourselves and change the model. And one other piece I just want to say is we used to spend money on public health. If you look at the spending on public health in the United States, it has gone down dramatically over the years. And that also is, what are we telling people? You should eat right, you should exercise, you should live in you should live in a place that's healthy for you. These are public health issues. And so it's a little bit upside down now that they're coming back to the industry to figure this out as opposed to public health doing what government used to do. So I give it to you.
Yeah. Thanks to my classmates for your support, and you probably find it interesting that I'm here on a panel on healthcare, because it's only in the second half of my career that I've been working in life sciences. And I moved in '99 to a small company that the entrepreneur had developed a new method for sequencing DNA. And you'll recall right around that time was when the reference human genome was sequenced. Tony Blair and Bill Clinton got out, and yeah, that cost about $1 billion. And if you want to think of how technology has changed the cost of sequencing, 7 years later, we did the first human genome as opposed to a composite genome out of James Watson for $1 million. And now it's under $1,000, approaching $100. So those of us who know Moore's law realize that the cost of sequencing actually has decreased faster than that. And at the time, it sort of created a buzzword of personalized medicine. Everyone felt, okay, now that we can identify all the genes that each of us has, how it's going to cause disease, how we're going to respond to drugs, we can be very precise in how we treat people. And Joe asked us to look out and maybe predict where we'll be in 10 years, in 2030. And there's really three trends that I want to highlight, and they really need to be, the technologies need to be here today if it's going to impact healthcare in 10 years, just because of the nature of healthcare being, pretty slow to change. If you're trying to introduce drugs, you've got to go through the FDA. And as an example, one of the drugs I started working on back in I think it was like 2004, just failed its pivotal clinical trial last year. So 15 years, before you get a yes or no as to whether a drug's going to get approved. But the personalized medicine, it is happening today, but I think it'll be even more so 10 years from now. You think about how many of you have had your gene sequence through 23andMe or some of those? So it's probably less than half of you. 10 years from now, I see it routinely happening to everyone, from birth and then on through. Where it's already impacting, and Linda could talk a little bit more about it, how we treat cancer. It used to be that we would get drugs approved for cancer based on where the cancer was located. Now we look at what the molecular pathway of that drug is. So certain drugs that may have worked for some people in lung cancer now might be used in other cancers where they have the same type of molecular mutation. It's going even further than that when you think about our ability now to take and create designer drugs. We often will sequence a cancer when a patient has it. The thought might be that we would actually then create a person's own immune cell response to that cancer, to that mutation. So recruiting a patient's own immune system, but typically now we're doing it through what might be called chimeric or CAR T receptors, you might have heard. But we come back to the cost that Phyllis raises. Treatments on that are $400,000. Just recently, another rare disease, gene therapy was approved. That's getting reimbursed at $2 million, the most expensive drug out there. Justifiably from Joe's economic perspective, because current treatment for that disease is $350,000, $400,000 a year. So you can see that over time, those drugs will pay back. But it is a big upfront cost to the system, and we have to decide on how we're going to treat it. But this trend to personalized medicine is one that you'll see even more in 10 years. A second one that I wanted to come to is, I think healthcare's been slow to adopt big data and artificial intelligence. If you look at what's happening in social media and our consumer retailing, it hasn't happened to the same degree. And maybe later on we could talk a little bit about why that's been the case. But I think 10 years from now it will. And It won't be just the genetic data that we're gathering. How many of you wear Fitbits or other types of motion activity monitors? Maybe a little bit more than we had on the sequencing side, but think of all that data that's being generated by those sensors and how we were going to be able to integrate all of that. And now that we have electronic health records and we can start tying in all this different data with potential health outcomes, we'll be able to unleash the power of big data into healthcare. So that's a second big trend that we're following at Elm Street and trying to make investments on. And then the third one is one that also was enabled through inexpensive sequencing, and it relates to what we'll call the microbiome. And people really didn't appreciate the great diversity in all the bacteria that live in and on us and the importance it has on human health. Joe mentioned, that's, the food aspect is important, but it's not just because of the nutrition, it's also impacting the microbes that are in your bacterial gut. And it's been shown that those have impact, first on your weight gain. So if you take, for example, with mice, obese mice, and do a fecal transplant so that their microbiome now is in a skinny mouse, it'll become fat, and then vice versa, even if you don't change the nutritional uptake for those different mice. So clearly, how we understand our microbiomes and how we work with them is another trend that I think for 10 years out will have a big impact on healthcare. And maybe we'll come back to some of that, Joe.
Sure,
but I'll pass it over to Linda.
Yeah, so those are all great points, and you sort of get an overview of where we're going in healthcare. So I always look at things through the cancer lens because that's the world that I live in. For about 20 years, I ran a breast cancer research program, first at Columbia and then at Cornell. And over the little less than 2 years, I was hired by Sloan Kettering to integrate a healthcare system into the Memorial Sloan Kettering families, a healthcare system called Western Connecticut Health Network, while still maintaining a small research footprint and still taking care of patients. So I'm sort of still in the trenches there. So when I think about what are the biggest challenges that we have, and actually what is oncology care going to look like in 10 years, in 2030? I'm like, well, okay, what did it look like 10 years ago? And I'm like, well, gosh, it looks absolutely nothing. Today, it looks absolutely nothing like it did 10 years ago. I think 2010, 2009 doesn't even remotely resemble. We didn't even sequence patients there. Now I would never not think about sequencing patients in order to think about how to optimally treat them. We think about immuno-oncology and some of the checkpoint inhibitors we have, which activate the patient's immune system to fight the cancers. Those were just a dream, or maybe there were some early clinical trials just beginning to start at that time, but now it's standard therapy across a wide variety of therapies. Back then, we didn't even know about something called human papillomavirus. I think back in about 2009, they were fighting to immunize like 15 and 16-year-olds with HPV because they said, well, that could prevent all types of cancers, not only cervical cancers, but a host of other cancers. And now when they think about people who have HPV-related cancers, I mean, there's about 1 million people a year worldwide. You can prevent those cancers. When you think about driving down costs, you think about ways, prevention. You think about hepatitis B vaccines, 1 million people a year right there. You think about HPV vaccines, another 1 million people a year. You think about driving costs just down like that. So healthcare's changed a lot, and a lot of the cancers that we used to see we're probably not going to see moving forward, providing that certain public health policies are put in place and implemented across the world. So I think that oncology as we see it today is going to be it's different every year, frankly. We just came back from the big oncology meetings that were in Chicago on Tuesday. But where is it going to be in 10 years? Well, I think certainly we're going to see a big development of immuno-oncology, activating the immune system. But right now, we're sort of in the dark ages of immuno-oncology in that, we're not really 100% sure who to give the drugs to. We're not exactly sure how to give it. We're certainly not sure how to manage the toxicities. Chris mentioned something called CAR-T, where basically they take your immune cells out, they educate them, give them back to you, but they're not really sure how to educate them properly yet. And while they've seen some amazing responses, there's still a lot of work to be done. And the thing is, well, yes, we sequence these tumors, we find where the problem is, we give them drugs that target that problem, but many patients develop resistance and the tumors come back, so obviously we're missing something. And that's where you're going to start to see this whole other thing come in called strategies which target the tumor, what we call the tumor microenvironment, because tumors don't come with their infrastructure, they co-opt it. And so the thing is we can globally change that microenvironment and interfere with that process of co-opting the infrastructure. It'll be another layer on how to stop, treat, and prevent cancer. So when you talk about the microbiome and the way that the body recognizes foreign invaders, and cancer is considered a foreign invader, that's another layer on which to treat and prevent cancer. So these are all, when you think about how cancer care is going to be looking in the future, that's certainly one of the ways. Now, the other thing you've probably heard a lot about, you've heard about gene editing, CRISPR-Cas9, and again, we're probably in the dark ages right now with gene editing, right? And as we look forward, there's probably going to be ways that people who have inherited predispositions or have acquired predispositions to different types of diseases, not just cancer, they're going to be able to fix themselves. Back in the 1990s when I was at Columbia, they were already trying to do this with gene therapy, but that was, again, in the dark ages. And as we move forward, there's going to be a lot more, there's improved technology in order to do this. And we'll see it even now in China, obviously. I saw a report, I didn't read it, that they thought these babies that they gene edited for CC5, I guess, which is
HIV.
Yes, but the chemokine receptor that they alter was something called CC5. Basically, to prevent HIV infection, they thought that there were going to be some issues, but I didn't get to read the article yet. But then again, little Louise Brown, 40 years ago, she was the first IVF baby. They thought there'd be problems too, and she's perfectly fine. So this is just the tip of the iceberg, moving forward in terms of what is cancer going to, what is cancer and other diseases going to look like moving forward. One thing that I also think that we're going to, that's really becoming into focus in terms of healthcare, and that there were actually two things. One is health equity, or what used to be called healthcare disparities. One of the things, and this is where technology is really starting to be integrated. So as I mentioned, the American Society of Clinical Oncology had their annual meeting this past weekend and past week. And we have this, it's very competitive with all these presentations, and then you have this big presentation on Sunday in front of, I'm going to say, 30,000 people. It's a big deal to have an abstract presented for what we call a plenary session. And the number one abstract for a plenary session was an abstract looking at how Medicaid expansion through the Obamacare reduced healthcare disparities between blacks and whites. And it was driven by Flatiron and data analytics. And basically what it showed was that in the 33 states where there was Medicaid expansion, that disparities, and they only looked at between blacks and whites in those states, that basically the time to treatment initiation was 4.8%, and it was statistically significant, and it was inferior for blacks as compared to whites. And when they had the Medicaid expansion, that the difference between time to treatment start, which has been associated with better outcomes in better cancer outcomes, was narrowed to 0.8%, which was exactly the same. And actually, time to treatment initiation was better for both groups overall with the Medicaid expansion as well as, and so that access to care improved, hopefully we'll be able to demonstrate improved outcomes, but definitely time to treatment initiation. And this was the first time that there's ever been a health services research presentation at our meeting, because we're always looking for new drugs. And this really signifies that this is really one of the important issues that we really need to deal with within oncology in our time, as well as trying to cure and prevent cancer. So I think that was really a big step forward. I think it's just the tip of the iceberg that we're going to start seeing, and it was really driven by Flatiron Health, the EHR, data analytics. So that's how things are going to be integrated. And then the last thing, and then I'll shut up so that people can talk, is the cost. The cost is out of control. And there are big programs called Choosing Wisely within American Society of Clinical Oncology, as well as American Board of Internal Medicine, to basically decrease healthcare costs where we can. But I will tell you, the drugs that we use in oncology are ridiculously expensive.
I'll agree with that.
Yes, the pharma should be completely ashamed of themselves. You have drugs that cost $15,000 a month, and they don't even improve survival. and I can only say, that I will tell you right now, I never talk politics. I do not like our current administration, but I will say that there is something which is moving through Washington right now, which I have to say I think is great, where with all the direct-to-consumer advertising that's there, any drug that costs more than $15 a month, they're going to put exactly what the cost is. So when you see Ibrance or Verzenio or any of these drugs you see on TV, they're going to see the price tag that's $15,000 to $20,000 a month. So I'm happy about that.
Let me jump in from the other
Yes.
perspective, Joe, and defend pharma if I can.
No.
You moved us right to topic 2, and
Yeah,
that was
exactly.
that's a
good
good one. Yeah.
segue. So,
Didn't you say it was 15 years until they found out that it didn't work?
but yeah.
I work with that.
No one
I work with
paid
that.
for
I
that.
work with that drug,
Yeah.
right?
No one paid for it because it never hit the market.
Yeah.
But and in fact, that is, if you read about the cost to create or to bring a drug to market, it can approach $1 billion when you count in all the failures. And so certainly, the question is, I think, and Joe will support, there's not an efficient market right now because information like a price is something that is very hard for consumers to get to see. When you have insurance, you want the best care. You don't care what it costs, right? Somebody else is, in essence, really paying for it at that point in time. So, there's a lot of big issues that Joe and our economists need to be thinking about. When it comes to the pricing of drugs, the example I just gave, there are health economics that do set limits. When the, what was it, the hepatitis?
Hep C.
Yeah,
Hep
C
C.
first came out,
Harvoni.
it was priced very high. And then, we
$86,000.
did have competition, and,
Still high.
and it's come,
But the interesting thing about
Right.
this, so that's going to prevent a liver transplant probably 20,
Right.
30 years from now.
Right.
So
Right.
the cost structure went up today, save money there, Medicare pays there. Who pays today?
yeah.
Just to be clear, is everyone familiar with this Harvoni and other drugs that cured hepatitis C, kind of a major innovation, and priced at, started at 100,000. Now I think it's like 25,000
Right.
for
I don't know if
8-week
it got that
treatment.
low. Yeah.
Well, the list price is different than the payment.
Right.
It's very common.
Right, but somebody's paying for it, right?
Absolutely.
Somebody's,
Yeah, yeah.
somebody's paying for it.
No, but at least that was the beginning, but that was in a price range you could actually think about.
Get your head around.
$2 million.
Right.
It says, yeah, you save $350,000 a year, take the present value, what's the discount value? I mean, you could come up with a rationale.
Right.
But that's not necessarily how you want to pay for it, because who's going to pay today? If you have a commercial insurer today, should they pay for that today? Even then, it's a lifetime of maybe it works,
Right.
maybe it doesn't, maybe after 5 years it wears
Right,
off.
right.
So there are lots of theories now about how to pay for that. Maybe you pay by year. First year you pay 50% of it,
Right.
next year you pay 10%, 10%. So this is an enormous area,
So
So wasn't
specialty
there a drug
drugs.
that was just approved for a spinal?
Yeah, that's the one I was
That's the
talking about.
That's the $2 million.
$2
Yeah,
million
that's $2 million.
project, right, over 5 years, yeah.
Yeah,
So
but they're spreading it over.
$500,000 installments per year.
And then the question is, what does insurance pay? What do you pay? Is it approved? Did the federal government approve it? I mean,
And it doesn't even restore function, right? It doesn't restore walking function.
No, but it prevents, worse.
Deterioration.
Deterioration, which is what the current treatment is. So, yeah, and what we're talking about is a different mechanism.
Right.
But, maybe if we have time to segue into a different controversial
Yeah.
topic that
Yeah.
you raised,
It's a whack-a-mole of controversial topics. There you go.
Yeah,
which is,
Cost.
so this is gene therapy.
Yeah.
So that's where, rather than giving you a drug, they're actually changing the gene that would make the normal protein in the individual. You allude to CRISPR and the ability for us to do that. A lot of these trends, the technology's there. Whether or not they'll be adopted in 10 years, there's political considerations, societal considerations. And I'm curious, you mentioned, sure, why not change a gene like this if it's, a debilitating disease? But what about HIV? And, should you be able to put, and the real issue why it was controversial in China was because they were doing it in an embryo so that
Right.
they could, confer this, and it not only would help that patient,
Right.
but it would also be in the germline so that, that patient's progeny would also have that,
Yeah.
now mutated or different gene.
yeah.
Certainly we would do it to prevent Huntington's disease.
Yeah.
But where do you draw the line?
Yeah, so I think the issues in that case was surrounding informed consent. So there's nothing, I would say there's nothing wrong with pursuing those lines of investigation as long as all parties understand what they're getting themselves into. And that's where there's in this country, there are very strong guardrails around informed consent and clinical research. So I think in China, the story that at least came back here, and I never know if it's really true or not, was that the informed consent process, even there, the guardrails they had there were not followed. It's an extensive, here it's an extensive process, an extensive review
Well, let's
process.
push it, let's assume that they were, that going forward, they will be followed.
Yes.
Would you allow genes to modify those, for example, genes associated with intelligence, would you let those be modified?
I think that we need to think forward. Yeah, I would actually. Because I think
If I want my son to be able to jump higher and be a better
yeah,
basketball player,
yeah, I would.
I can.
Something normally my default is always no, but I think you have to think about these things. If that's something that you want to do and you're willing to pay for it, and, I would say leave well enough alone personally, but, because you could say the same thing, in my world, patients who have breast cancer, some of them carry mutations that predispose to breast cancer, right? BRCA1 and BRCA2. And so you can actually do IVF, you can selectively edit out those embryos that have BRCA1 and BRCA2 and implant embryos that don't have BRCA1 and BRCA2.
Right.
So that's the world I live in. Is that right or is that wrong, right?
Yeah, this is a fascinating because I think about genetically
So do
modified
I believe in
corn,
stem cell
people get
research?
very
Yes.
upset about it.
Now,
Now we're talking about genetically modified kids, so that's
So-
interesting. Have you seen Gattaca? No. Anyway,
So
what do you think, Phyllis?
Well, I think that the promise of precision medicine is extraordinary. I think the fact that my sense of how we treat cancer now is a little bit of whack-a-mole. We try this drug, it works for a while.
Yes.
Try the next drug, we'll
Yes.
try that.
Yes.
Sometimes it does work, but we really don't understand because there are really 1,000 diseases here. We call it cancer, that's lung cancer, but there are 1,000 types of. So I think that's kind of the goal. I do think we're very far from it because you can talk about the EHR, the electronic health record, where we all have data, and we think now we have it electronically. This is golden. We're going to sequence the
Take all these-
exome or the whatever
yeah.
the genetics. I don't even know. And we're going to match it with the electronic health record. We're going to have all this data, and now big data. We're going to give it to MIT, and they're going to solve everything. The data is horrendous. Even it's not written now. Now it's just in print. I mean, it's in the computer. It's not in the same place. Doctors struggle using the electronic health record. To think that we're going to be able to capture that data and match it is, this is like we're almost there, but we're so far from being there.
So we call it garbage in, garbage out a lot of times with the EHR.
So when we think about where healthcare is going, though, this sort of explosion of data availability,
Right.
and then when we start to use it and realize this is garbage, there'll be incentives to hopefully
But
get it
it'll
to be
take
better.
time.
So
It'll
it's going to take some time.
And how do you standardize? I had a board member once when I said, I guess we were just doing coding, something simple, and it was the head of one of the large credit card companies, and he said, I charge everybody $50 a year no matter what. Doesn't matter if they use it once, 100 times, how they use it. I don't care. Just keep it simple. He said, makes sense. Gee, I got about 70,000 codes I have to use for ambulatory surgery alone, about 20 or 30,000 diagnostic codes, and the federal government tells me this, and that's how you get the data. So it's too complex.
To me, it's fascinating. The economics, the incentives. The reason why I see a lot of coding and maybe games played with coding is because it affects reimbursement.
Get money.
Anything that affects reimbursement, suddenly there's cottage industries of people maximizing against that. So
Has good return.
we have to think about that as we put in new policies that change the way we pay for healthcare. That's for sure.
So in oncology, because I was just at the meetings, there is an initiative through ASCO to basically standardize coding in oncology. They're calling it M-code, so that they'll be able to scrape stuff out of the EMR to utilize the information that comes out of it. And that's a brand new initiative that they've just started. I don't know anything more than that.
We have about 30 other topics to go. I think maybe we could open it up to the audience, though, and then we could start over here and work our way around. Yeah?
The actualization of the system is silly, but written as or expanding the VA to cover all the citizens and residents of this country. Where every hospital becomes a national federal facility, every doctor and nurse is on a federal salary, and the pharmaceutical industry is heavily regulated. And you support that? Because I think that's the only solution you're going to have to control the cost.
It's a big topic and one that we'll hear a lot about in the next year and a half.
sure.
What do you think?
Well, I personally don't think that that's a good solution for us. I think that I think now we have a variety of performance, good and bad. I think when you go to that, this is my own intuition, is you got a level that's, I wouldn't say mediocrity, but it's a level. If you let that level, I think that's good because that gives access to everybody to that level, but I don't want to lose the extraordinary work that gets done. We do some extraordinary things in oncology and other areas where we'll push the envelope in the United States, and I think you'd lose some of that.
Yeah, I mean, so from my perspective, and again, I'm dyed-in-the-wool capitalist, is, I think if you don't have competition, you really introduce a lot of inefficiencies in the system ultimately. So yes, you can argue that it might, that it might be more efficient, that might be one way to address some of the costs that we have right now. But I think that you're going to then, disincent innovation. I think you'll wind up with, big issues in terms of having sufficient capacity. So, I'm not a supportive of that type of system.
I think you do need some minimum universal health care in this country, absolutely. I mean, you
But
need,
there's ways you can do that.
Right.
and
many
you need
ways.
multiple tiers. So like, for example, if you look at the UK and the NHS, there's a minimum that you have there. But if you look at outcomes in the UK, they have very poor outcomes in cancer. I mean, they're in the, I'm going to say in the lower third. Their healthcare outcomes are really not that great. However, I will say from a drug pricing perspective, they're unbelievable. So for example, there was a myeloma drug that came out, I'm going to say maybe 15 years ago, and they refused to pay for it unless patients got a benefit from it. And so I thought that was really great, and we should do something like that in terms of, I hate to keep on going back to the drug pricing.
It's what
I'm sure it's from like, I don't know, some country's name I can't even pronounce, and you have all those little robocalls.
But there are more pushes towards that, aren't there, Linda? I mean, I think.
Not really.
I thought Repatha was one where Amgen went to a pricing model where it had to show efficacy to get reimbursed.
Not here, I'm not aware.
They're starting
That would be
now,
great.
just starting some of the.
Now, it hasn't yet
Yeah,
made it to
so-
oncology, but yeah.
Yeah, but I think that, we need to, but I think people need to be able to opt into different levels of healthcare. So like, some people want to pay for healthcare, other people don't want to pay for healthcare. I mean, you even see it here, because you'll see people pay for concierge healthcare. Other people pay for some things in between. You see it in the plans that we choose from our employers, what level of healthcare you want. There has to be a certain minimum, because, you really can't have delays. I mean, you need to have basic healthcare here. You really do.
I mean, there's so many different topics there. There's access, there's cost, there's quality, and they're all impacted by the potential solution of a nationalized healthcare system. So this idea that we should treat people when they get sick is not controversial. We're not going to turn people away. We shouldn't. And so then we have to think about how to pay for that. In the U.S. anyway, we were talking about in the 90s, health insurers started to ration care more, and people got furious over this. If we talk about the government rationing it with strict price controls, that is not a popular idea in the U.S. I just don't see it coming about. And then there's the last resort is Phyllis. Phyllis is going to decide. No, the hospital providers, we're going to put more risk on them to decide where they should cut back.
Or
on care.
what's worse, doctors. I find this so offensive, frankly. Physicians, there's an oncology program the federal government's running, which is, they're incentivized to give cost-effective care. Now, hopefully the doctor is doing the right thing and taking care of that patient. That should be first. And yeah, they shouldn't waste money when they don't need to waste money. But I don't, frankly, want to go to a doctor with that incentive.
I think somebody has to make the decision. So who's going to make it? I'd rather in the government I think voters trust doctors a lot more than than the
They
government.
trust the nurses more than the doctors.
Or maybe the
now.
nurses.
Yeah, but there are different ways to cut healthcare. For example, the Choosing Wisely program that ABIM put in was like, do a CAT scan instead of a PET CT scan. The difference in cost is like $4,000 or $5,000, right? Choosing an anti-nausea medication that, maybe you only need, we call it low emetogenic, for low nausea. Don't give them something that's high nausea if they only need low nausea. They don't need that. So why are you giving them something that they don't need?
But
But
I
we're
see.
trying to
you know,
structure,
yeah,
I think,
right.
that, and Joe's working with it.
Yeah, but a lot of it relates to education, right? Because
Right. I think
There's
that you don't have to
education
necessarily
deficit.
pay somebody differently.
Right.
But if you put in
Yeah.
big neon signs
Yeah.
that you're wasting money,
Yes, the
guess what?
wasting.
As a physician, you're going to say, maybe I ought to take a look
Yeah.
at this. Maybe that's a better way to take care of the
yes,
patient.
yes. And it's
But the
education.
patient,
Well,
the
yes
advocate.
and no, Phyllis. So
It's
I'll
a
use
hypothesis.
I'll use hand washing as an example, right?
Right.
Yes.
The easiest way to prevent hospital-acquired infections is better hand washing.
Yeah.
You could put signs up. It wasn't until they started putting a penalty on that the rates started going down. Hospital.
Yeah, we've seen examples where you give financial incentives for people
But they-
for physicians to wash their hands.
Financial
And
incentives.
not only do you see washing go up based on secret shoppers, but also you see
how it
infections
goes.
go down, which is kind of amazing when you think about
Right.
real world, real patient outcomes from financial incentives. Listen, we got one from over there. Let's go in the middle. All right, how about you? What do you
So 40 years ago, I sat in a class at the school talking about the value of a life. How much do you spend to save a minor who's in a K-bin? And certainly this $2 million drug raises that question again. Is that even a conversation we can have in this time?
I'll tell you, I think it's worse than that. I think that, what we're seeing now is, you get an MRI, you can go for $500. Why go to the big hospital for $2,000 when you can go to the guy down the street for $500? One, you'd argue whether the quality is the same. But assuming it's even the same, I can disaggregate my cost structure. I could do it for $500. I didn't pay more for the MRI. I buy 10 of them. He buys one. So that's cheaper. I'm not, nothing's more expensive on the, in the real cost structure. So I can do that, but what's a transplant going to cost? $2 million? $3 million? $4 million? Should Medicare pay that for somebody over 65? Should Medicaid pay that for somebody poor?
And who chooses?
Right.
So we can't, nobody's even talking about that, but if you really try and disaggregate, I call we scrambled the egg. I cross-subsidize inpatient and outpatient care and low people who lose money and Medicaid. 30% of my population is Medicaid. I can't live on Medicaid. Well, guess what? Commercial payers pay me more, thank goodness, because they're subsidizing the government payers. So it's a very complicated kind of financial operation. And I don't think anybody wants to have the dialogue that you're talking about. End of life care. When do you stop doing the chemotherapy? Is it an extra 2 weeks? Is there a wedding that you're going to? Or is it 2 weeks more of suffering?
Yeah.
There are lots of discussions. Weren't those death panels at one point?
Oh, yeah.
So,
No one's having those conversations.
Are you as an economics, health economics?
Yeah, so this idea of this committee in the UK, for example, and lots of places around the world do this, it's called NICE, which I think is kind of interesting.
Yeah.
It's a committee
Yeah.
that thinks about cost effectiveness.
Yeah.
And they will have a £50,000 cost per life year saved. So it's quality adjusted life years, but in any event, you think about how much do we value an extra life year for someone? And then they have a price cap that says we're not going to pay more. If your drug increases life years by 1, we're not going to pay more than $50,000 for the drug for the year. So as you see, when they're choosing that number, that's basically a price control based on what they think a value of a life year is. And voters, basically, in the end, we think are deciding. So economists come up with how do we, as a society, think about that number. And there are 2 ways we do it. One's with markets. So people take risky jobs where there's a big risk that they're going to die, like fishermen. Their wages are higher because it's riskier. And there you can get numbers, something like $5–8 million per life, statistical life, not the boy in a tunnel or something where we basically would go to the ends of the earth to try to get them out. But if it's like, are you going to reduce the chances of dying, then we can put a dollar value on that. Another place we do that is with, say, speed limits. When we raise our speed limit, it saves everybody here time, which we can value, but it actually leads to deaths. We know that that's going to happen. Governors signing that bill are signing that more people are going to die now in my state. And so we can think about how much are we willing to pay. And there you get lower numbers, like about $1 million per life, that the voters, if you will, are trying to decide. So we have ways of trying to value that in economics, and then they filter into our regulations of thinking about where do we spend our money, how do we bend the curve, how much are we willing to pay for a drug. That number has to be part of the conversation, and it's an uncomfortable conversation. How much are you willing to take away money from education and other priorities we have to raise the dollar per life year that you're willing to stomach in the healthcare system? It's a fascinating
Yeah, so in
question.
oncology, they're starting to look as a quality metric, patients who receive chemotherapy within 30 days of death. There are no penalties associated with it yet, but that's starting to emerge as a quality metric.
And there was a fascinating study about as you go to palliative care, what's the trade-off? It's less toxic, obviously, that's the point. But maybe you have fewer days. And it turned out in this one famous study, it extended life
Yes.
and was less toxic. And then everybody
less.
jumped at that. That's what we want, a win-win. And then we're
Right.
going to see more and more, hopefully, more research on that, but then pushing toward less toxicity at the end of life. Okay, we went from there to there, I think. How about over here? Do you guys have a question? We had 100 hands before.
When are we going to see more outcome transparency, both on the consumer side and also like payers?
Well, I would say in oncology, every trial now has to have patient-reported outcomes. It's pretty much a requirement.
But
And-
outside the clinical trial
Oh.
world. So I'm
Well,
going,
I
I
mean,
want to figure out
yeah.
which doctor do I go to, which health
Yeah.
system
Yeah.
do I go to, right? Where's my outcome scorecard where I can
Well,
navigate
I think the underlying question really is what's quality? And that's not well defined. I mean, I've looked at mortality data, and I figure mortality data that is supposedly severity adjusted or patient adjusted seems to me a little more black and white, and I feel pretty good about some of that. And that data is available. You can see that data on CMS websites. There's data on certain, heart failure, some of the large COPD, some of the large disease categories. And then there's also reported data, probably, I'm not sure where, but there is a lot of data in the state. In New York State, we have a lot of data by hospital. I don't think you'll see it by doctor.
So
It's
this
not-
is
it's not as easy
controversial.
to
Go
get
ahead,
as it
Chris.
should be.
Yeah.
And, there
people-
are efforts to,
Yeah, people don't access it that much, but there really is. You can put the hospital in, and there's actually a lot of data on each hospital on the CMS website. Because
Yes, right. If you go to hospitalcompare.gov, I think there's every hospital and various quality metrics. There's a joint commission on quality that it's actually controversial in the industry because how much administrative burden do you want to have people checking boxes of what they're doing versus just doing things? And so the more and more reporting requirements on are you doing the, say, evidence-based procedures. So for example, have you asked someone did they quit smoking? They have to document that they did that, and the more they document that, the higher their quality score goes up, even if it's not even correlated with better outcomes. If you ask people, how's your smoking going? I mean, may or may not be beneficial. Now, there are other things like blood thinners for people after a heart attack. Lots of evidence, it's low cost, has lots of benefits. We probably do want people to be doing that, and then so we monitored that for years, and the puzzle there was some hospitals were slower at doing it than others, but now basically they're all doing it. So should we still be monitoring that they're doing it, or can we just say, okay, that metric has gone? I did one study, and I'll just very briefly, trying to compare apples to apples of hospitals is very difficult because the patients do differ. So we looked at which ambulance arrives when people call 911 within a neighborhood. This is all across the country, but the statistics was comparing people within neighborhoods. If you got the hospital ambulance to come to your house, you're much more likely to go to that hospital. If you get the FDNY, you're likely, or the New York Fire Department, you're more likely to go to the closest hospital. So which ambulance company was a shifter, which hospital people go to? And we use that randomization in a technique called a natural experiment to sort of mimic a randomized trial. And there we found if you were randomized to hospitals that do well on these CMS hospital compare measures of quality across a long dimension of quality measures. So that's risk-adjusted mortality, risk-adjusted hospital readmission, quality best practices, this is the Joint Commission type stuff, and patient satisfaction. We found if you went to a hospital that rated better on those quality scores, mortality was actually substantially lower. So that was a validation exercise that if we compared apples to apples patients, they got better outcomes.
better.
Better outcomes.
But
If you go to the better scored.
And now that I have one foot in a community hospital, sort of see, they really care about quality, and that's going to be their differentiator because they really focus on those metrics. The Press Ganey, the patient satisfaction. Does someone say hello to you when you walk in? How clean is it? What kind of services do you have? And they're going to be all publicly available because competition is stiff.
Right. So I would say when I make a decision to find a doctor, I don't really care if the food's great in the hospital.
Right.
I mean, it's
Right.
unfortunately, that's what they're using for HCAHPS. They're using these types of, did you
HFs
get greeted?
are-
Are you happy? What did they, did they listen to you? Did they hear what you had to say? I mean, some of them are relevant, but some of them are like, really? It wasn't quiet at night? I know it'd be better to sleep, but it'd be better to have the best surgeon doing that surgery.
Right.
Right, when I found that those that were rated better on those measures had better outcomes, our intuition was that they were just better run hospitals in lots of ways. It wasn't necessarily because they had better
because of
food,
one
but
thing.
maybe they were better managed. So it's interesting to unpack those results as we go forward. All right, we'll go back over here. All right, my introduction was so good, I'll go there.
You will.
Thank you. You've talked about transparency and big data and EHR. I'm wondering about the interconnectedness of data and whether that might be either private or public push, because we're still in silos and there's no data that's, especially with patient privacy rules, there's no big data across the system, which is still limiting all of the different factors of quality and care and access, and particularly cost. Do we see that there will be pressures brought to bear by the private or public sector to increase the breadth, I guess, of the access to data?
So with the EHR, there are systems that talk. So for example, if you have the Epic electronic health record, every Epic system can talk to each other. You can just go into Epic Everywhere and see other hospitals that have Epic. There are also health exchanges, where information exchanges, where you can access. So the connectivity is getting much, much better.
Hospitals are still sort of fighting each other.
Well, it depends. So there's some that, it's not perfect, but I'll tell you, if you're on the same system, then usually, especially with Epic, unfortunately is the most expensive, but it's the best.
And Linda, you find that true? Because I've heard people
Yeah.
say that different instances of Epic
Yeah.
don't work well
How
with
many
each
of you
other.
have used Epic? Anyone used Epic? Okay,
So-
now of those people, keep your hand raised if you like Epic.
Okay, so let me say, I started using Epic. You go to, when you stop using Epic, that's when you really like Epic. So I started using Epic in 2005, and I complained about Epic all the time when I was at NYP and at Cornell. I was like, oh, I hate Epic, I hate Epic. And then I went to MSK and Norwalk, where they use Allscripts and they use Cerner.
And it looked good, huh?
I love Epic, that's what I'm going to say. So Epic is like the king.
But
Yeah,
I do
I'm
think
serious.
it's true where you talk about different
Yeah.
instances, because frankly, after you do some acquisitions, I think we had 9 different electronic health records, different systems. So we're now in conversion. We are converting to Epic, which was a very hard decision for us. We really didn't want to, but we're going to go on one instance across 10 hospitals and 2 medical schools.
That's great.
So we will see everything in that. And you're right, I even see as a user of Epic, when I went to the doctor, it says, do you want your Epic record, because they saw me at some other place, brought in here too, which I thought was a little scary, because
Yeah,
I don't know that I want everybody knowing everything about me. I mean,
Right.
That connectedness, I think we're far from really doing that, because I don't think people are willing. First, this is about who owns the data. I mean, we're talking about that now. We're collecting a lot of data. We're worried now how many of our vendors are really taking our data and we don't know it. We're going into our contracts now to protect the HIPAA privacy of all our patients, because people are scraping data. So pharmacy data is one of the interesting, when I ask about how can we figure out how patients are moving around without being an insurer, we're not an insurer, and people tell you to look at the pharmacy data. So I don't think there's a good answer yet, but it's a very tough area.
Yeah, sure.
Chris, do you see things from the investment perspective?
Well, data has value, and the challenge, Jill's question is, who owns that data? And I think we're naive to say it's only going to come out of the health records. There's that data is getting collected and generated in a lot of different ways. All of you who raised your hand about 23andMe, I mean, your data is being used by Glaxo now, I believe, to develop new drugs. So there's definitely information where there's incentives to gather it that is being gathered. And the question is, who should own it? Who should have control over it? And I think as a society, we're going to have to deal with that.
And who will monetize it?
Well, right now, yeah. To me, it should be the individual who has control over it, but that's not the case today.
Yeah, to me, it should be the individual, but the organizations that have the data, it's an asset.
Yeah.
And it doesn't seem like they want to give up their assets that easily, and that's why I think there will be a policy response at some point, but that's a policy debate, and let's see where we're
And I think the consenting will be a big issue. What does the patient consent to?
But I think you're seeing the pushback on tech now on some of the social media and, the data that's been generated that way. So, hopefully that'll continue on into, health records or health information as well.
All right, we probably have time for a couple more questions. Let's go in the middle.
We talked a lot about the pharmaceutical cost, which is the right thing to do. Are we talking about the electronic health record cost? Each system spends about $300 to $500 million just to install Epic in itself, which is great, but there's a cost shift happening in the healthcare industry to the IT world. Is it creating the value we expected to provide at the moment? Does it provide the value we expected to provide?
We're hoping.
I mean, that's the question for Phil.
Look, in many respects, it's a facilitator. It allows you to do things. And then the question is, from a management point of view, what do you do with it? I mean, you have access to better data. You have more information. You can watch your referrals better. You can look at better you can push out protocols. Right now, we probably had thousands of different order sets because we have these 9 different electronic medical records. We have gotten doctors together in different groupings from these 10 sites to say, okay, what is the order set we're going to put in Epic when we install it the same across all? So now you've got physicians arguing about the best way to take care of that patient. Mm-hmm. That's actually pretty powerful. And then you'll be able to monitor when people aren't doing that. Is there a rationale? Are they outliers? Are they practicing properly? So there's great opportunity in this. And there's a lot of work, again, a lot of this work that we're doing now to prepare for this, I think is important work.
So when I think about, if I see presentations by healthcare consultants and so on, at the end their slide is by Epic. And the answer is because they can get reimbursed more easily with all the coding that goes into it. This is when I see presentations like that. So that's a little bit cynical, like why they want to be able to have their revenue. So you get that platform, and the question is, with any new tool, it takes time to learn how to use it. So talk about order sets. That might be the way that the committee at the hospital has decided, for this situation, we're going to order these tests. If they wanted to change that at MIT, we would think about randomizing the order set change. And doctors don't have to use the order set, but we know the power in behavioral economics of defaults. So as you change what's the default for this condition, you see massive swings in that direction, and then you could actually track outcomes to see if outcomes are better if you use the new one versus the old one. That, to me, that would be
You have a great opportunity with us.
Yeah, we're partnering with alumni like Phyllis to do exactly those kind of tests. All right, we went there. I guess maybe one more over there, or we can come. Yes?
So as we're talking about the future of healthcare, I wonder how much thought or conversation is going or is happening around the workforce. So, see you all nodding your head. So Medscape came out with their physician burnout survey, and the results were pretty grim. So what is happening around that space as more and more physicians are either going concierge just to maintain the quality of life, or in some terrible situations committing suicide?
Well, you want to start, or me?
Yes, I mean, so I would say that this is a tough one. So I would say that the trend has been that physicians are considered worker bees. And physicians are, in many ways, are just like for the most part, really like what they do. So they don't want to be bothered with a lot of the other stuff. So I would say they ceded a lot of control. And by the time they woke up and saw that things were happening they didn't like, it was too late. And so that's where, the burnout comes in. That's where the systems come in. That's where there's never integration of input into workflows and things like that. So I'd say where it is right now, and I think that it will probably change, is that right now I would say, including myself to some degree, I'm a worker bee, right? But I think healthcare systems are starting to realize that physician satisfaction, or healthcare provider, because we know we use a lot of PAs, we use a lot of NPs, we have healthcare teams really, that they need to be engaged, and you need to have a satisfied workforce. So I see the trend, now that I have a half administrative hat on, you need to really engage your workforce, and so you're beginning to you're beginning to ask the questions, you're beginning to utilize the input. But it's been very tough.
Can I just say, I think you start with doctors here in this, and there's been a lot of talk about the burnout, and there is and suicide has been a result of some of these. And they're taken to heart by institutions. We now have, it used to be doctors got 100 emails a day bombarding them, and so we've tried to say, okay, we're going to try and put it all in one small piece with bullets if you want to expand it to try and give better satisfaction. We've taken our residents used to do medicine reconciliation on all the patients. We're moving that to pharmacists, taking that responsibility away from them. In the old days, they used to do blood draws. Now you have phlebotomy teams. They used to do pushing patients. Now we got escorts that do that. There's a lot. The electronic medical record has been very hard for physicians. It's an enormous burden. And until we get maybe natural language processing.
Which is available.
So, no, but to the extent, they've used it in radiology for years. It's somewhat harder, apparently. I don't know why. It seems like it shouldn't be, but, and be able to recognize it and put it into the medical record, into the right fields, and then we'd have the data that we want, because it'd be in the right fields. I mean, that's a little bit of what we need to get to. It's ridiculous, right? What's going on now. So it's a problem. But I want to talk about another part of our organization, which is really a lot of the work that people are doing that are not at physician levels, a lot of clerical work. I look in the accounting department, there's a lot of work we do that could get replaced by these robotic process automation, the RPAs. And we're doing a little bit here and a little bit there, but I would almost tell you that, if you look at managed care contracts, they're commercial contracts, they're rules-based. I said this 20 years ago to Siemens. Why are you not just building in the rules? And why do I have all these people having a dialogue with a patient where nobody knows what they're supposed to do next? But nobody did it. Nobody made the investment. And so I would just go back to years and years ago, there were 5,000 hospitals out there. And everybody was different. It was cottage industry. And nobody in IT really invested because everybody was one-off. So now you've got a lot of systems. And I think there are 100 systems that are 50% of the revenue in the United States now or something like that. And you've seen you've seen that consolidation in the healthcare industry. And you've seen it in Allscripts and Epic and whatever, Cerner. There's a handful now that have really survived and are big. So there's opportunity now, and I think IT can make that investment, whereas they couldn't make the investment before, it couldn't pay off. But we have a lot of work to do. We have a lot of catching up.
I think actually that's the perfect place to start. We have a lot of work to do. When I just reflect for a second, we're a part of an amazing community of MIT alumni and MIT community of people who are thought leaders, but also thought doers, and doer leaders, if you will. So we're out there trying to make change with you and with the panelists. I hope you can join me to thank our panelists for